COIN, Community-Oriented Integration Network, is a network of friends, people of experience, who explore how to develop local communities for health, compassionate communities. Community-oriented integrated practice is concerned with creating collaboration for health and care at local level. We argue that it involves creating umbrellas that you go under every so often in order to escape from the madness of everyday life. But not all the time. You oscillate between the two. And in these umbrellas, you're able to find new ideas from other people. You're allowed and helped to dig inside your own experience to reveal more, and also explore things that you don't feel you've got the time to look at during the chaotic everyday life, the things that are on the too hard to look at pile. In this edition of the Journal of Holistic Healthcare, that is the spring 2024, Louisa Uni writes a lovely paper on flourishing spaces. Now, she describes a flourishing space are engaging with our humanity, honouring each other's individuality while learning also from each other. And then a lot more. It's a great paper, please read it. She, in my mind, is describing what happens underneath an umbrella. You escape from the transactional way of everyday life, the multiple balls in the air having to deal with things, and you re-engage with the connectivity of your humanity. In the same paper is a wonderful paper by David Colintomi, if I can find it. Oh, well, I'll have to remember it. David used to be the National Programme Director for Primary Care, the so-called czar of primary care, working at central government for 10 years under the parties of the left and the right and the centre. He's also a GP, very well known, very highly respected, and a wonderful human being. He describes in his paper here with the future of primary care in the UK and hopefully elsewhere as well. And I'm remembering two things from this lovely paper he's written, and one is the need for continuity of care. Now, if you think about it, continuity of care is a bit like going under an umbrella, because you're going to see someone who you know and trust, who remembers you, or hopefully remembers you, or has enough memory or notes about you to be able to connect with you, that you feel you can continue on a journey with. So you're replacing the idea of doctors as administrators of medical science, of doctors diagnosing and treating one thing at a time, to doctors, GPs I'm talking about, but all primary care workers and hopefully all doctors, seeing that you're dealing with a human being who has multiple parts to their lives, including their connections, their multiple aims, their multiple illnesses, and being able to help someone make sense of all of this. Now, to follow this idea through, you could say that every person needs continuity of care with their healthcare providers, except it's absolutely not possible because it's far too much, really. Every individual GP has on average something like 2,000 patients. And there's no way that you can work out a way of continuity of care for those people. And also, not everyone wants it or needs it. There are some people, however, who benefit from more than others, and particularly they are those who are elderly and infirm, those who have long-term conditions, and those who have multiple conditions. Because if different people are dealing with different parts of your body, who is there to help you see the whole, to help you see that you're actually trying to live your life story out in a way that makes sense to you, and the discrete part you're treating in that time, let's say your heart or your liver or your head or whatever, is only part of that life story that you're developing. So continuity of care could be seen as an umbrella, and it could be that it is particularly available for those people who have carers. Now, carers are important because they already exist. They are 1/10 of the population. People who are there for free, they just land there, who've got an impossible job, who have to deal with large numbers of different professionals, who have to do whatever comes their way, including dealing with good people who want time with the person who's caring, and people who are determined to upset the apple cart. The carer has to deal with all these things, very often 24/7, very often unacknowledged. How about GPs offering continuity of care for 10% of the population and support who have carers? And that 10% of the population, the carers, are also supported to take their part as members of the extended primary care team. Not talking about paying them, asking them to do exactly what they're doing now, but better supported, better trained. And other professionals who relate to the same household can offer exactly the same thing. So district nurses, palliative care nurses, social workers, faith traditions, corner shops, pharmacists can all relate to the same household as well, so that the household, not just the individual patient and the carer, but the household is gaining continuity of care from a team of maybe 5, 6, 7 professionals who know that they have a named responsibility to that household. And then, over a period of time, those professionals get to know each other as a team around that house. They agree with themselves who's going to help who. They can start off with maybe some intensive stuff like a case conference or whatever, but quite quickly move to distance things like follow up by mobile phone or FaceTime or something. I mean, I know that when I was caring for my wife, I cared for her. She was sick for about 4.5 years before she died at home about 5 years ago. One of the things that was enormously stressful was not actually practical stuff like food. It was who's going to sign the death certificate if we go past the period of time when the GP has to see her before she dies. Now, that's the kind of anxieties that keep carers awake late at night, that are oh so easily solved if people are aware of them and if they have continuity of care. Also, everyone described already exists. Now, it might be that 200 patients is quite a lot or 200 households is quite a lot for one individual GP to be able to deal with, but they too can work as teams, as multidisciplinary teams inside their practice. So there you have the potential access to develop the kind of horizontal and vertical thinking we're talking about to make health and care everybody's business.